hypertension, how is the hypertension caused in patients? Sorry, I'm doing some recording elsewhere. Then we also see that these conditions are manageable. So we'll start with our first slide to get the definitions and the course outline for this lecture, or the outline for this lecture will go as follows. One, we'll see what hypertension is. We want to know the pathophysiology of hypertension. We also want to have the classes of hypertension with their specific examples. We would like to understand the mechanism of action of the antihypertensives as well as the therapeutic indications, because these drugs may have other indications. Then we should be able to know the contraindications and potential drug-drug interactions that are in place. By definition, plainly we say hypertension is defined as persistently elevated arterial pressure, blood pressure. A persistently elevated arterial blood pressure is preferred for a reason. So if we want to define blood pressure, we usually take it after assessing the patient. So precisely we say hypertension is a persistently elevated arterial blood pressure above 140/90 millimeters. We have given that because of variation in body weight, age, and some considerations that are in place. But on average, that is the limit when we will be able to conclude that this person is suffering from hypertension. We have also seen that on average, many average weighted patients have a normal blood pressure range, on average being as 120/80 millimeters of mercury. So the normal blood pressure is supposed to be on average as 120 systolic over 180 diastolic millimeters of mercury by measurement. So anything that is ranging above this is an eye opener, but may not necessarily be concluded to be hypertension until it reaches above 140/90 millimeters of mercury. If it's above that, that's when you can conclude. And in many cases, the blood pressure we measure depends on the body activity. When the body is active, the pressure usually tends to rise because the oxygen demand will cause the increase in heartbeat, so leading to increase in blood pressure. So in many cases, there are ranges of normal blood pressure that we always take it to be within the limit. But for the purpose of really knowing what is abnormal and what is normal, we should be able to get specific limits of specific units that will help us to know what is normal and what is abnormal. Of course, blood pressure ranges are like the systolic can range from 100 to 139 or 129. But in most cases, when we have 100 to 129, that is normal, depending on the body weight. Even there are people who have blood pressure of 130 systolic, which is normal. But the lowest diastolic blood pressure is about 60 millimeters of mercury up to up to 99 millimeters of mercury. But when it reaches 100, 101, 102, that is eyebrow raising. We always take precautions. And sometimes what we take as normal blood pressure range can be very detrimental to some patients, depending on the prevailing circumstances. So, blood pressure is persistently elevated arterial blood pressure that is above 140 over 90 millimeters of mercury. When it is like that, we can conclude it is hypertension. And the word here is persistently, meaning it must be after repeated measurements. And so, when a patient comes in the clinic and you measure it for the first time, you take the BP for the first time as one of the topicals, you should be able to repeat it maybe after 2 or 3, after 5 minutes in order to assess its stability. Because sometimes when patients arrive, they get excited or anxious and blood pressure can go high due to the white coat or some patients having threatening conditions around them that can change the blood pressure. So you need to settle the patient and measure the blood pressure after calming the patient down. And you repeat it after every 5 to 10 minutes in order to be sure of the blood pressure levels. And so when you continue to measure it at least for 3 times and it is persistently high, like above 140, that's when you will say, the blood pressure is high. And that's where we now suspect and put it to be that the patient is suffering from the effects of elevated blood pressure. And these are the most common cardiovascular diseases, which is for the age group. Those days it used to be the disease of people who have aged up to 60 years or even up to 69, 70, the disease of the old age. But these days, due to I don't know whether the economy or the type of life we lead, the diet, many people who age around 40 are at a high risk of getting hypertension. So hypertension starts to set up in age range of 40, especially in our era. People who are suffering from hypertension range from between 40, even others are 30s. But it is rare for people who are on the age of 30s. So at most, people who are at 40 above are at a high risk due to their lifestyle, and it is a disease of the inactive people. If you are not very active, you are always sedentary, living in one place, not active. You even want to live a utopian life where you want people to bring everything for you. Even sometimes going to the loo, you want to sit on a roller. That type of life is very dangerous. You even want people to bathe you. I hear some people are employing their colleagues to bathe them, even to scratch, to feed you. That kind of life is very dangerous. So your only business is to swallow, because no one can swallow food for you. And that kind of life is what has brought a number of challenges to people. So restrict yourself and make yourself active, exercise and do a number of things in order to be active. And these are the same things that you're going to encourage patients to do in order to really remain healthy. And so generally, there are two types of hypertension. We have primary or essential hypertension. We have secondary hypertension. Primary hypertension is hypertension of unknown cause, but secondary hypertension is hypertension of known cause. So how hypertension occurs is what we can now discuss. Generally, hypertension comes or sets in as a result of increased cardiac output. This increased cardiac output occurs as a result of increased blood volume, which you must take note of. So what brings about hypertension is 1, increased blood volume in the body, 2, excess sodium intake, 3, renal insufficiency, and 4, increased peripheral resistance, which comes as a result of vasoconstriction. And so when vasoconstriction occurs, there is narrowing of the blood vessel, which makes it hard for blood to pass through, and that causes the heart to overwork and push the blood with a lot of force, and that is recorded by the aortic arch as the increased blood pressure, and the aortic arch is actually barometer of the body. So when it records increase in blood pressure, the body responds by doing some compensatory activities that sets the patient restless, and many things tend to occur. For example, where it will lead to excessive stimulation of angiotensin aldosterone system, renin-angiotensin aldosterone system, which can also cause the overactivity of the sympathetic nervous system, and this can also enhance more of the vasoconstriction. And so when the increased blood volume, the increased peripheral resistance, and also the excessive sodium intake, including renal insufficiency, that brings about the hypertension is not resolved. That persistently elevated unresolved arterial blood pressure leads to a lot of complications. And this can cause cardioarterial diseases. It can result into myocardial infarction. It can bring about cardiac failure and renal insufficiency, even the dissecting aneurysm of the aorta, and many other complications that are in place. And so that alone, if not resolved, can bring more complications than what we have just narrated. And so, unfortunately, these conditions have very rare signs and symptoms. By the time they show up, will be the time when they have really become too much beyond tolerance, and they can cause loss of life. One of the things I wanted to emphasize before I move ahead is the fact that if the hypertension is set and we want to detect the hypertension, the question usually arises that why are we interested in arterial blood pressure? We are interested in arterial blood pressure but not venous blood pressure because the arteries take blood to the tissues and supply nutrients for the metabolic needs of the body cells. And so if there is insufficient blood supply to the tissue, then it means we are not having enough oxygen. And therefore, we are saying that this alone will be able to inform us on the complications that are there. So we want to say that arterial blood pressure is very essential. Arterial blood pressure is very essential because it helps us to know whether the tissues are receiving blood or not. And that's why we take note of the arterial blood pressure instead of the venous blood pressure. Somebody is typing and your slides are not changing. I do change the slides and we are doing well unless there is somebody who has a challenge. The slides keep moving. Only that I take long to talk on them. But if you want me to run with the slides, I can do so. But I just wanted to illustrate some specific things before I begin going on with the slides. Now, in general, hypertension is usually as a result of either arterial damage or increased afterload, and the pathophysiological pathways have been shown in this tree diagram that you can follow, where the hypertension here can be as a result of increased afterload that comes with the systolic dysfunctions or left ventricular hypertension or myocardial oxygen demand. And we have also seen that the left ventricle hypertension comes with the diastolic dysfunction. Then we also see that these systolic dysfunctions can actually come as a result of heart failure, so eventually leading to hypertension and the rest. So you follow it from that perspective. Some of the hypertension can arise as a result of arterial damage due to accelerated atherosclerosis or weakened blood vessels, and many of them can actually lead to complications that we now see as like hemorrhagic stroke. We can see retinopathy, aneurysm, ischemic stroke, and so forth. And that's why if we don't treat hypertension, we begin to see the patient suffering from this kind of conditions like stroke, like heart failure, like retinopathy, failure to see properly, and other necrotic conditions that come in. So that's why it's important to treat the hypertension and always encourage the aged group of people to measure or check their blood pressure frequently, because it is very rare to detect it timely, but it only needs to be monitored now and then when you are at high risk. So you encourage patients to do that. Management. Now, in management of hypertension, once the hypertension is known, we see that we can manage it by two approaches. One is non-pharmacological approach. Using a non-pharmacological approach, we also have pharmacological approach. Now, using non-pharmacological approach, we can encourage patients to lose weight, because when there's too much weight, the heart gets overworked. And so we see that nothing will get lost if you lose the weight. Instead, it will be beneficial. So you encourage the voluminous patients who are really overweight to really lose their weight. It is supposed to be a controlled weight loss, just not excessive one. Then the weight loss is in a way that you encourage the patient to exercise also and do anaerobics. And once they do these anaerobics, they should not eat weight-gaining foods. They should just eat fibrous foods. They should take a lot of water in order to wash away the metabolites. And this kind of exercise helps to, cause vasodilation and increase circulation of blood, which supplies oxygen to the body parts, and also makes the person to become streamlined, and it is easy for such a person, even for the heart to work. So when vasodilation occurs during exercise, it makes work for the heart to be low, and the functioning of the heart will always be efficient. So encourage patients to lose weight, and encourage restriction of sodium intake, which means the salt intake in meals should be low and restricted. You should also, for those who take alcohol, you encourage them to reduce the alcohol intake so that it becomes moderate, not really too much. Then pharmacologically, we use a number of drugs. There are very many drugs that are used in management of hypertension. Unfortunately, when we give these drugs to clinicians and nurses, they become overexcited and they want to use the drugs at random anytime. No, there is a specific way in which we use these drugs. Once a patient comes to you, you must be able to know whether this patient is drug naive or drug experienced. A naive patient is a patient who is experiencing hypertension for the very first time. But a drug experienced patient is a patient who has been on antihypertensives for some time and is coming for consultation, maybe to change the drug. So you will have to assess this patient with proper history taking for better management. Now remember the principles of managing the patients, the hypertensive patients, is that we must bear in mind that the first naive patient might have elevated blood pressure, mostly at most because of increased blood volume. So we don't just jump direct to start variety of drugs. So we aim, our first objective will be to reduce blood volume by administering diuretics. Diuretics cause diuresis. They increase micturition, and when the micturition is increased, it reduces blood volume in the body, hence reducing workload for the heart and leading to resolution of the hypertension. And that is one of the principles and objectives that is used in management of hypertension. And the diuretics are of of very many classes. The most common ones that are used in management of hypertension include the first three that I've indicated here. One is the thiazides and related agents. The thiazides include benzofluothiazide, which is a first line for naive patients. The hydrochlorothiazide, which can be combined with other drugs. We have chlorothiazides. Then we also have another group of diuretics which are loop diuretics. I'm very sorry, many people are complaining of voice breaks, too much echo, and so forth, but I'm in a hall. So maybe that's why there is an echo. If there is any break, it is because of your network. At least here today I have no problem with what? I have no problem with the the network. Somebody has asked a question. Amanya Victor, I've seen your question. That if the blood volume is decreased and the electrolytes are regulated, won't a patient have cardiac failure? No, Amanya. The blood volume increases and it means the blood volume is too much, giving too much work for the heart. Therefore, the reduction of blood volume will be of help to cause the stability of blood pressure. Then somebody is saying the slides are spinning. I don't know what that is up to, but on my slide, on my computer, the slide does not spin. So even I'm not on webcam, I've just, unless it has been in the setting. So let's continue. I was saying that the thiazides can be used to treat hypertension. The loop diuretics can be used. Actually, when the hypertension is, we have what we call as hypertensive crisis, the loop diuretics are best because they are of high efficacy. That's only where it's mostly used for the drug-experienced patients who have resistant, uncontrollable blood pressure. So we also see that the hypertensive, the loop diuretics can be used and they cause rapid drop in hypertension. Typical examples include the furosemides, which you commonly know as Lasix, and I don't encourage you to know it as Lasix. It is furosemide, which is internationally known. And so we also have others like bromotenide, torsemide, ethacrynic acid. These drugs were used in also management of heart failure. We also have potassium-sparing diuretics, which include amiloride, trimethoprim, spironolactone, which we have used also in management of heart failure. There are other diuretics like osmotic diuretics. You have ever used mannitol? Mannitol is one of the diuretics which is used to resolve the cranial pressure, especially during head accidents that cause injury in the head, where blood vessels have, got blocked or blood has accumulated in the brain and it needs to be removed. We can sometimes use the mannitol to remove it, and that it is done in order to reduce the blood pressure that is built in the brain. That will cause discomfort to the patient that has got challenge with during certain accidents. So the accidents that affect the cranial region where pressure is built due to accumulation of blood in the brain can be resolved by use of some of the osmotic diuretics like mannitol, where it is administered and it circulates in the blood and causes withdrawal of water from the surrounding and leads to diuresis. And it resolves the pressure in the cranial region. But the hypertension can be resolved by the first three drugs, which are in the group of diuretics that I have. That have continued to help in management of patients. Another group of drugs are the beta-adrenergic antagonists. As I told you, we have the lols, the metoprolol and atenolol are of help here. They are the best drugs of use because they are selective. So when these drugs are used, they help to reduce, they help to block the stimulation of the heart so that the workload for the heart is reduced. And then we also have the alpha antagonists, the sinners. We have the prazosin, the terazosin, the doxazosin, which block the alpha-1 receptor and cause vasodilation. And these drugs help to reduce hypertension by reducing the peripheral resistance. Remember, when vasodilation occurs due to use of the alpha receptor antagonist, the constriction is relieved or is widened, and the blood vessels become open due to vasodilation. Then there will be easy flow of blood through the blood vessels, and that relieves the pressure on the heart, and hence the overall result is reduction in hypertension. That's why they are used. There are other drugs that we also use, like the mixed adrenergic antagonists, like the labetalol, carvedilol. They are only used when there is need to kill two birds using one stone, where we want to reduce the contractility of the heart, where we also want to, block the blood vessels. We can use the mixed adrenergic. When we talk about mixed adrenergic, it means these are antagonists that are non-selective. They block both alpha and beta receptors and cause wide effect. So we use them when there's need. Then there are those centrally acting drugs like methyl dopa, clonidine, guanabens, guanafishen, and so forth. These drugs act on the central receptors, especially in the CNS, where they bind to the alpha-2 receptor. Remember, alpha-2 receptor is autoreceptor. Once it is stimulated, it stops the release of neurotransmitter in the synaptic cleft. And when these drugs go to bind to alpha-2 receptor, they affect other nerves and cause blockade of nerve transmission. And where there is overstimulation of the nerves become inhibited, and that alone helps in reducing the hypertension or blood pressure. And that is the reason. And in most cases, this methyl dopa, the clonidine, are used in management of hypertension in pregnancy, which we refer to as eclampsia or eclampsia, and they are commonly used. It's only of recent that methyl dopa has been withdrawn for a while. It is only used when indicated or when there is no other drug working for those patients. Otherwise, it has got so many effects that make it not be used, which we shall look at later. We also have the adrenergic neuron blocking agents like the guanadrel and resapine, which are selective for the synaptic knob, where some act as false neurotransmitters and cause the blockade of transmission, and this can help in reducing the hypertension, where they stop or inhibit the stimulation of the heart or myocardium. Then another group of drugs are the calcium channel blockers, and these calcium channel blockers are of various types. For those who watched the video of antiarrhythmic drugs, the dysarrhythmias and the resolution of tachycardia, we also use calcium channel blockers. Even in a treatment of angina pectoris, the calcium channel blockers are also of help. And so, in the same way, hypertension can be treated with the use of calcium channel blockers. The only challenge is that when we are managing hypertension, we don't hurry to touch the heart directly. We just have to manage the conditions that are surrounding the heart, like increase in blood volumes will be reduced, or we can cause vasodilation, but not touching the heart directly unless it's now necessary. In the management of naive patients, I have seen people prescribing calcium channel blockers as first line. That is very dangerous, because when you begin to tamper with the heart of a patient, you are driving the patient nearer to the grave, because the electrical balance of the heart will be disorganized. There will be reflex tachycardia, there will be myocardial infarction. Some of these calcium channel blockers actually present high risk of myocardial infarction. And once the heart becomes compromised with the infarction or infarcted cells, then the patient is likely to die very soon. So we should not really hurry to introduce chronic use of calcium channel blockers. Otherwise, we try to shorten the lifespan of this patient. So that does not mean that they are not used. They are only used when indicated rationally, and they are brought in where there is necessity. Now, the typical examples of calcium channel blockers include the verapamil, the diltiazem, then a group known as the dihydropyridines, which include the nifedipine, nicardipine, felodipine, isradipine, amlodipine. All those dipines are actually useful. The only calcium channel blocker that many clinicians have become obsessed with in the use is nifedipine. This nifedipine is in use because of the fact that it has got affinity for the alpha-1 receptor, which is found on the smooth muscle of the blood vessels. And so when they use nifedipine, it tends to block the alpha-1 receptor and causes vasodilation. And that vasodilative effect is the one that reduces the peripheral resistance and resolves the hypertension. Though it has got very little affinity for the calcium channels on the myocardium, which can also reduce the contractility of the heart. And those are some of the calcium channel blockers that help in reducing the heart contractility. They cause muscle relaxation and hence reduce the workload and also oxygen demand by the heart or myocardium. Just like other conditions, the hypertension can be resolved by targeting the renin-angiotensin-aldosterone system, where we play with the renin-angiotensin-aldosterone system instead of touching the heart. And so, in that we can use angiotensin-converting enzyme inhibitors. Actually, it is one of the second line or first line drugs that you can give to the patient. And so, these angiotensin-converting enzyme inhibitors like captopril, enalapril, lisinopril, quinapril, ramipril are very useful in getting the hypertension resolved. And so the hypertension gets resolved because when the angiotensin converting enzyme inhibitor is used, it blocks the conversion of angiotensin 1 to angiotensin 2, which is a potential vasoconstrictor. So when angiotensin 1, conversion of angiotensin 1 is blocked, obviously there will be no vasoconstrictor. So the blood vessels will remain dilated, hence allowing easy flow of blood, which reduces workload for the heart. And then the overall result is reduction in blood pressure. If that fails, maybe due to non-compliance of the patient. I remember the main effect, unwanted effect of angiotensin receptor blocker is the dry cough, which brings non-compliance. So, in this case, we see that if a patient is not compliant with the captopril or any other angiotensin converting enzyme inhibitor administered, you can switch to the angiotensin receptor blockers, which we call as ARBs. And those losartan, candesartan, irbesartan, telmisartan can also help to block the angiotensin receptor type 1 to cause vasodilation, which reduces workload for the heart, hence resolving hypertension. And it is one of the either second line or third line drugs that we bring in when we are managing. And in most cases, when we now switch to management of hypertension using angiotensin receptor blockers or angiotensin converting enzyme inhibitors, some of them come in form of combination, which we shall learn later. I have seen a question from Amanya Victor that in hypertension, the blood pressure is already high. And during exercise, blood pressure also increases. So I'm wondering how high exercise can resolve this. I believe that's what you wanted to ask. I'd already said that, Amanya Victor, when patients exercise, the physiological, the endothelium secretes some intermediates that cause the vasodilation to occur. So during exercise, vessels become dilated, and that allows the exercise to increase blood supply to tissues. And that vasodilation alone causes reduction in blood pressure. And that is actually how it resolves itself. So the exercise keeps the blood vessels open and hence easy flow of blood. That reduces the hypertension. That's why we encourage people to exercise. Back to the classes of drugs that we manage, we use for management. We are saying that we can also use another set of drugs like the vasodilators. The vasodilators include hydralazine or hydrazine. We can also use minoxidil. This minoxidil has been abused by the adolescents to grow beard. And those who have bald head have always abused it because it causes vasodilation, and the vasodilation makes hair to grow on the surface. That's how it is abused. But it is one of the drugs that is used for causing vasodilation. We can also use phenoldopam and the diazoxide, even nitroprusside, which is both venous and arterial vasodilator, to resolve this condition. So it is helpful in management of hypertension. So vasodilators generally help in reducing the peripheral resistance that eases the flow of blood through the blood vessels and reduce workload for the heart, hence resolving hypertension. The last drug which is of recent, is renin inhibition. The renin inhibitors, which is recent, the aliskiren. The aliskiren is a recent drug which inhibits the renin. Of course, when renin is not released, the renin angiotensin aldosterone system is not stimulated, hence blocking that kind of vasoconstriction, and that will still keep the blood vessels, open. Hence, vasodilation, which reduces the hypertension. So those are the types of drugs that are used in management of hypertension. And remember, the principle of managing hypertension is that one, we should target to reduce the blood volume, which can form one of the objectives. Two, we should target to reduce peripheral resistance, which comes by causing vasodilation in various ways. Three, we should target to reduce the stimulation of the heart, which can come as a result, which can be done by using adrenergic receptor blockers or even central acting drugs that can give a wide effect. So those principles help. Now, in many cases, the patients are mismanaged. So when a naive patient arrives, the first thing to try is to reduce blood volume and monitor the patient. And we usually do that by administering diuretic, preferable the thiazides as first line. The benzoylfluothiazide has been the first line. Even in clinical guide, you will see it, because we target to reduce the blood pressure by decreasing the blood volume. Usually when the blood volume is decreased, it does not go beyond certain limit. It usually balances and brings down the blood pressure to normal. We don't take it beyond. And usually we keep monitoring. And when it has stabilized, for a naive patient, we can wean the patient off. But for drug-experienced patients, we need to monitor and see which combinations work better. And I'll be able to take you through after discussing the individual drugs with their mechanism of action, unwanted effects, and drug-drug interactions. That might take us longer, even including the next lecture that will be still talking about the antihypertensives. We now see the diuretics. Let's look at the diuretics as a set of drugs used for managing hypertension. And when I'm talking about diuretics, we are also at the same time discussing the effect of drug on the renal system. So when it comes to management of renal disorders, we should be able to appreciate the effect of these drugs on the renal system. So it's like at the same time I'm discussing the management of renal conditions or renal insufficiencies that are in place. So the diuretics, we see that we have very many classes of diuretics. These include carbonic anhydrase inhibitors like acetazolamide, the osmotic diuretics like mannitol, we have the thiazides like the hydrochlorothiazide, we have the loop diuretics like the furosemides, we have potassium sparing diuretics like the spironolactone and so forth. And so these are the very drugs that fall under diuretics. As I said, in many books they will say the exact mechanism of action is not known. But we know that these diuretics, from the physiology of renal system, these diuretics interact with the thiazide sensitive sodium chloride co-transports in the kidney nephrons, and usually they help in decreasing the extracellular volume, and that helps in reducing the cardiac output. And we have seen that when we use thiazides like the bendrofluothiazide, added advantage of using them is that they also promote vasodilation. I think that's why they are used as first-line drugs. That's the tendency they have in management of hypertension. The thiazides also inhibit carbonic anhydrase, and there is increased loss of potassium ions, though it's not effective when the glomerular filtration rate reduces up to 30 millimeters per minute. Now, I want to bring your attention here that when we are using these drugs, we should be mindful of the glomerular filtration rate. These drugs only work well when the efficiency of the glomerular or the kidney is at a certain limit. If it is too low, say with the filtration rate below 30 millimeters per minute, then the thiazides may not be recommended. Otherwise, if it is must that we use it, then there's need to do dose adjustment for such patients in the management of their hypertension. And so these diuretics also have their unwanted effects. Common unwanted effects include CNS toxicities like xanthopepsia, we have weakness, general body weakness, even having vertigo, like where you feel like having the head making you to see as if the earth is moving with you, yet that is vertigo. Then it can cause erectile dysfunctions. It has some hematological defects when chronically used. So those are some of the unwanted effects. We also see that the drug thiazides in general tend to interact with the digitalis or the glycosides, cardiac glycosides, where they are contraindicated when a patient is on digitalis or like digoxin or digitoxin, because they cause increased cardiac activity. Then they are also contraindicated, or they tend to interact with the corticosteroids like prednisolone, like hydrocortisone. When they are used together with those drugs, they tend to amplify the loss of potassium ions, leading to hypokalemia, that is reduced levels of potassium. They also interact in a way that they can cause lithium ion toxicity due to decreased excretion. The thiazides reduce effects of NSAIDs, especially in synthesis of prostaglandins. So that is where we have challenges with the use of the thiazides in management of hypertension. So these diuretics, much as they interact, they are still of use. We use them when they're indicated. Let's now turn to receptor active drugs. That is drugs that bind to the different receptors that are targeted. For example, we have beta receptor blockers, which can be selective or non-selective. And we appreciate that when these drugs block the receptors, for example, beta 1 receptor blockers, when they block it, they stop the stimulation of the heart and then hence reduce the workload and oxygen demand that resolves the hypertension. Even for non-selective, some of them are able to bind to the alpha-1 receptors and stop the stimulation of the sympathetic wing as well as the blood vessels and resolve or block the vasoconstrictions, reducing the peripheral resistance, which allows the easy flow of blood and reduce workload for the heart, hence resolving the hypertension that is in place. So the primary mechanism, of course, you now know, and these beta receptors are located all over, including the juxtaglomerular complex, which is in the kidney. And when they block the beta receptor, of course, that stops the secretion of renin and reduces the circulating angiotensin II as well. And in addition, the myocardial contractility is also reduced, the heart rate is reduced, the cardiac output is reduced, and then the CNS stimulation is also reduced, the sympathetic nervous system stimulation is reduced, even the baroreceptor sensitivity on the aorta, that is the aortic arch, is also altered, including the peripheral adrenergic neuron functions that are altered, and the prostaglandin synthesis is increased. Now the prostacyclins are actually vasodilators during exercise and other related effects which cause vasodilation and reduce the hypertension. Then we have unwanted effects of these adrenergic receptors, some of which include sedation, sleep disturbances, bronchoconstriction, loss of libido, which is indicated here as impotence, but it's not really. Then increased glycerides and reduced high density cholesterol, lipid cholesterol, which is challenging, but we can always see how to reduce it pharmacologically. Especially the non-selective antagonists tend to precipitate epinephrine-induced bradycardia and hypertension. And we should also note that sudden withdrawal of the beta receptor blockers is dangerous because it can cause a rebound hypertension. And the good thing is that these beta receptor blockers are used in management of all grades of hypertension. And they don't cause salt and water retention, that's the good part of it. They are preferred options in patients with myocardial infarction an ischemic heart disease, and even chronic heart failure. So you can use them in many conditions. That's the advantage. Then the next class of drugs include the adrenergic alpha antagonists or alpha receptor blockers like the prazosin, doxazosin, terazosin. These inhibit arterial resistance, or they reduce arterial resistance and increase venous capacitance, accommodation of blood in the vessels, and this leads to a sympathetic reflex, probably, to really cause the mobilization of blood, to cause increase in venous returns. But when we increase capacitance, the cardiac output is reduced, and in that way, the hypertension is also reduced. The good thing probably may not be so serious is that the alpha receptor blockers or alpha receptor antagonists don't alter right fibrillations, or even the filtrations, the kidney filtrations, they don't alter. They also don't they can sometimes cause postural hypotension. They don't cause salt and water retention. And those are the advantages. They reduce plasma, low density lipids, cholesterols. They reduce also triglycerides. The good thing is that when we use them, they increase the useful high density lipid cholesterol, the HDLCs, which are of use. And so that's the advantage of using them, but we should use them with caution. They have their own unwanted effects, which we need to take care of, where especially they cannot be used in monotherapy, because when they are used, like doxazosin, can increase the risk of chronic heart failure. It is also associated with the fast dose phenomenon where hypertension can go high, or there is a hypotension which brings collapse of the patient, which may need resuscitation. That's what we call it, associated fast dose phenomenon, which can even be kind of hypersensitivity. So in most cases, it's not recommended as a monotherapy, but it's used in a combination. Some of the drugs that we use are actually now, duplicated. The labetalol, the carvedilol have the same mechanism of action, except they bind to both receptors, causing their effects, which means their effects are widespread. They are used to treat hypertension and symptomatic heart failure, which is useful. Now, the drug I want to emphasize here is methyl-dopa. When you will be going for ward work, and if some of you happen to go to labor suit, you may find or may not find use of methyl-dopa. But if you don't find, it means it's ruled out because of certain unwanted effects which we are going to discuss immediately after here. Methyl-dopa is a central acting agent, a very good drug in management of hypertension in pregnancy. It is a prodrug and activated by the adrenergic neuron by the monoamine enzymes. The active compound is usually stored in secretory vessels as a substitute for norepinephrine. It acts in the CNS to inhibit adrenergic neuronal outflow from the brainstem, and which means it tends to displace the norepinephrine from its vessels and becomes a false neurotransmitter, and that way it blocks the, the, the flow of neurotransmitters. However, this drug has the following pharmacological effects. One, it helps in reducing the vascular resistance, though it does not change the cardiac output and heart rate in young people, which means it is more effective in the elderly. It also helps in reducing the renin secretion, and salt and water often gradually is retained. That's the unfortunate bit. And this kind of effect tends to reduce the efficacy of methyl dopa, or in resolving the hypertensive effect. Unfortunately, when this drug is used, it has a good number of unwanted effects, like causing sedation and depression, CNS depression. It has some Parkinson-like syndrome. When mothers are on this drug, they tend to exhibit some Parkinson-like syndrome or movement, which makes them very anxious. Another serious effect of the drug is that it induces hyperprolactinemia, which results into gynecomastia and galactorrhea, excessive secretion of milk, breast milk. And when we use this to non-breastfeeding mothers, it's not healthy. So such brings the drug to be restricted in use. Above all, we also see that the drug causes some form of hemolytic anemia, which is dangerous to a pregnant mother. So we don't usually use such a drug in management of these conditions. And I know what has given a red card to methyl dopa is its tendency to cause hemolytic anemia, yet we need enough blood for the pregnant mothers, leave alone its tendency to cause galactorrhea and hemolytic anemia. So those could be some of the challenges that have made it to be phased off in management of hypertension. But in certain occasions, it is useful. Since it is used, the methyl dopa is very sensitive and helpful in management of hypertension in the elderly. We can always use it to manage the hypertension in elderly. Another group of drugs are the alpha-2 receptor agonists, like guanabant, bethanide, bretylium, clonidine, guanafacin, or guanafacin. These stimulate the receptors in the brainstem, resulting in decreased outflow of norepinephrine or sympathetic stimulation, and these also activate the alpha-2 beta receptors of vascular smooth muscles. And when the alpha-2 receptors are stimulated, they actually inhibit the release of neurotransmitters, hence stop the outflow of the nervous stimulation. That alone will reduce the blood pressure. And so they are usually used to diagnose pheochromocytoma, which is a kind of tumor of the adrenal cortex. And if plasma norepinephrine does not fall less than 500 picogram per ml 3 hours after oral dose, then it means the excess norepinephrine is produced by the tumor of the adrenal cortex or on the adrenal. So that is how it can be used for management, but it's also useful for treatment of hypertension. Its pharmacological effects are that when these drugs like guanafacin, the bretylium, clonidine, when they are used in management of in management of hypertension, their pharmacological effects are like reduction in peripheral resistance. They help in reducing peripheral resistance. They reduce heart rate and stroke volume. They also reduce myocardial contractility. They may cause postural hypertension and may lead to chronic heart failure, but when properly monitored, they can be controlled. The unwanted effects of such drugs include the CNS effects like sedation, vivid dreams, nightmares, depression, xerostomia, postural hypertension, and many others, including withdrawal symptoms. So they should not be withdrawn suddenly. They should be weaned from the patient gradually with reduced doses. Guanadrel actually acts as a false transmitter. It accumulates and is stored in the norepinephrine vessels, and once it is accumulated in the vessels and released on stimulation, there will be no stimulation of the receptors, and it is only reserved for patients who don't respond well to other antihypertensives. So these are one of the last options of drugs used when all other drugs cannot help in resolving hypertension of a patient. We go to Guanadrel, which is a false neurotransmitter, so that it resolves the wide stimulation of the systems that are in place. The pharmacological effects are that it usually decreases the peripheral vascular resistance by blocking alpha receptor mediated vasoconstriction, and though it has reflex sympathetic stimulation, which is a possibility, and that is useful. Unwanted effects include hypertension, fatigue, retrograde ejaculation, that is the gynecomastic tendencies. Something to do retrograde is where you ejaculate after the performance of sexual act. When you are resting, now semen begins to flow when you are done with the function, which is very disorganizing, and that is what we call it retrograde ejaculation. So those are the challenges with the Guanadrel use, but it also interacts with the tricyclic antidepressants, especially even when somebody is in use with the cocaine, even where the person competes for the drug competes for transport sites and the other effects that are related. Then Resapine, as one of the antihypertensive drugs, usually binds tightly to the storage vesicles at neuronal terminals and inhibits concentration of catecholamines into vessels, which means Resapine inhibits the release of catecholamines like dopamine, norepinephrine, epinephrine, and that way the overstimulation of the heart and vasoconstrictions will be resolved, and that makes that causes the process to resolve. Now our time is up. Sorry, our time is up. We can now move on, and here we stop with the lecture abruptly. We shall continue in the next lecture. Sorry for the abrupt stoppage. We hope to have better discussion of the rest of the drugs later. I believe you have now got a better understanding of hypertension. You have got the principles that are used. Remember that we target to reduce the volume of blood. We target to inhibit the overstimulation of the heart. We also target to cause vasodilation in order to reduce the peripheral cholesterol resistance. Thank you for listening. Remember to tap the likes or make comments, and also share it with your friends to understand the management of hypertension. Next time, we shall look at the drugs in a perspective of which drugs are best for first line, which ones are best for second line, how do you make the combination of drugs to resolve certain conditions in the hypertensive tendencies, especially in the hypertensive crisis. Thank you for listening. Wish you all the best and happy new year. Wish you all the best. Thank you. Bye.